Okay. Good morning, everyone. Buenos dias. My name is Ishizawa at Osaka in Japan. And thank you, Professor Sontini. And I'd also like to thank Christoph, a son of Professor Sontini and a friend of mine during my stay in Paris. Today, it's my great honor to have a chance to give a talk about the clinical applications of intraoperative fluorescence imaging to HPB surgery. On disclosure slide. The ICG fluorescence imaging is based on the fact that ICG emits fluorescence signals when illuminated with near-infrared light. And in the field of HBP surgery, fluorescence imaging can be used for visualization of the extrahepatic bile ducts, identification of hepatic tumors, hepatic segmentation, and perfusion assessment. Originally, I developed the fluorescence imaging technique for visualization of the bile duct by intrabiliary injection of ICG or intravenous injection of ICG because ICG is excreted into bile 100%. And I thought that the best indication of fluorescence choreography would be lab core because the conventional radiographic choreography exposes patients and surgeons to the radio waves, and this would be the world first case of lab core with the use of ICG fluorescence imaging published in 2009. And recently, we can see a lot of consensus guidelines about the use of ICG fluorescence choreography in the setting of lab core. And ICG fluorescence choreography can be used not only during cholecystectomy, but also for hepatectomy. For example, in this case, we are going to remove the left liver, preserving the Spiegelian lobe of the liver. So the ICG fluorescence imaging is used for delineation of the hepatic ducts running on the hepatic hilum. Here we can see the bifurcation of the B4 and B2 plus 3 branch. And here we can see the small branch draining the Spiegelian lobe, draining into the B2 plus 3 branch. So first, I encircled the B4 branch with the use of fluorescent choreography. This is the conference between the right and left hepatic duct, just in case. And after the division of the B4 branch, the B2 plus 3 branch is encircled, preserving the B1 Spiegelian lobe branch. Finally, this branch is divided and biodrainage from the Spiegelian lobe is assured. Then let's move on to the next topic, the liver tumor localization. One day in 2008, I found that liver tumors showed really strong fluorescence signals from before intraoperative administration of ICG. I didn't understand this phenomenon at first, but after the accumulation of similar cases, I started thinking that the liver tumor showed strong fluorescence signals, probably because the ICG that had been injected preoperatively for the preoperative liver function test could accumulate in the hepatic tumors. That's why the liver tumors showed fluorescent signals. Because in our department, almost all patients underwent preoperative ICG retention rate test for the estimation of the background liver. In fact, on the cut surfaces of the resected specimen, the well or moderately hepatocellular carcinoma tended to show the cancerous fluorescent signals emitted from the cancer itself. In contrast, in poorly differentiated hepatocellular carcinoma and colorectal liver mets. Here we can see the ring-like fluorescence signals emitted from the non-cancerous hepatic parenchyma surrounding the tumor. Today, I don't have enough time for the explanation of the background mechanism, but anyway, we can use this phenomenon for the intraoperative visualization of the hepatic tumors, irrespective of the fluorescence patterns. If the ICG was injected intravenously within 2 weeks before surgery as a part of a routine liver function test. And this technique can also be used in the setting of robot-assisted surgery. This is the Da Vinci hepatectomy. Here you can see the fluorescence signals emitted from the hepatic phrenic surfaces of the liver like this. Then this kind of imaging is very useful for setting the hepatic transection line. Of course, the ultrasound should be used for the to obtain the information from the deeper aspects of the liver. But anyway, fluorescence imaging is also useful to set the hepatic parenchymal transection line. And then this technique is also useful for the estimation of the location of the tumor during parenchymal transection. In this case, the right hepatic vein is going to be preserved, and fluorescence imaging, firefly imaging was used occasionally to confirm the surgical margins. Then the hepatic parenchyma is transected, exposing the right hepatic vein like this. And this is the wide surfaces of the right hepatic vein, and the tumor is visualized on the fluorescence images. Finally, this is the last branch, venous branch, draining the tumor into the right hepatic vein, and this branch is divided, assuring the surgical margin. And finally, the tumor is removed. The surgical margin was negative for cancer in this case. The hepatic segmentation. And in 2008, the Professor Aoki, the Japanese surgeon, published a really important article introducing the use of ICG fluorescence imaging for the hepatic segmentation in the setting of open surgery. And in 2011, when I stayed in Paris to learn laparoscopic HPB technique under Professor Gaillet, we modified the Professor Aoki's technique to be used in the setting of laparoscopic hepatectomy and published these techniques under the name of positive staining technique and negative staining technique. In positive staining technique, the tumor-bearing portal vein is punctured and very small amount of ICG is injected directly into the portal vein. Then the tumor-bearing hepatic segment is visualized like this under the irradiation of the near-infrared light. Then the surgeons can perform the really accurate segmentectomy of the liver. But this technique is technically a bit demanding. So when the root of the glissoniensis is accessible, easy to access, the negative staining technique is easier than the positive staining technique. In negative staining technique, the root of the cancer-bearing portal pellicle, in this case, the root of P6 is closed with a vascular clamp, and ICG is injected intravenously. Then here we can see the clear demarcation, the enhancement of the ischemic area of the liver with the use of firefly imaging technique. This slide summarizes the initial outcomes of use of fluorescence imaging in robot-assisted hepatectomy in our institution. Totally the 26 patients, and the success rate of hepatic segmentation, sorry for that, the sensitivity of the tumor localization by fluorescence imaging was 84%, and we used positive staining technique and negative staining technique in 1 case and 9 cases, respectively. The perfusion assessment is a very easy technique. We only need a bolus injection of ICG. For example, in this case of the robot-assisted Whipple procedure, we are going to confirm the arterial flow from the common hepatic artery to the proper hepatic artery before dividing the gastroduodenal artery. Then the ICG is injected, and Firefly imaging is used to directly confirm the good arterial flow to the liver. So thanks to this kind of imaging, we can safely divide the gastroduodenal artery. And let's see the future fluorescence imaging technique. In our department, we are developing the new fluorophores, which may enable visualization of the pancreatic adenocarcinoma and pancreatic juice. And this technique is based on the enzyme action, the hybridization of the enzyme. And after this kind of reaction, the non-fluorescing probe emits very strong visible fluorescence signal of HMRG. This is the background of this technique. And recently, we identified the pancreatic cancer specific probe named GPHMRG with the use of the library of the enzyme activatable probe. And let's see the pancreatic juice imaging. This probe is also hybridized by the pancreatic chymotrypsin and shows really strong visible fluorescence signals. And this is the peak model of distal pancreatectomy, and the pancreas is divided with a stapler device, and this probe is sprayed directly onto the stump of the pancreas. Then here we can see the pancreatic juice leaking from the stump of the main pancreatic duct of the peak. So I believe that in near future, intraoperative fluorescence imaging will develop into essential intraoperative navigation tool, enabling us to understand the accurate dissemination, accurate area of the cancer spread with some kind of the functional information of the organs, which may enhance the surgical outcomes. And let me introduce about the ISFGS, the International Society for Fluorescence Guided Surgery. And this is a really interesting story between Japan and Argentina. This is the fluorescence chromatography I presented, and I had a chance to present this technique at the IHPBA meeting, which was held in Buenos Aires in 2010. After that, a lot of surgeons started using this technique. But after the presentation at IHPBA in Argentina, Argentina was really, really nice place to see a lot of rainbows and have very good, great, fantastic beefsteaks. But anyway, after the presentation, I got an email from Dr. Fernando Deep from Argentina, and he said that he also started using fluorescence chromatography. So please let me know the background and how to use ICG like that. But to be honest, I thought that this mail would be the kind of spam mail because I didn't know the Dr. Fernando Deep. But 2 years later, I got an email from Fernando again, and he told me that he's just moved to the Cleveland Clinic, Florida from Argentina, and his boss, Professor Raul Rosenthal, has much interest in fluorescence guided surgery, and we are going to create the International Society for Fluorescence Guided Surgery. So let's do that together. So I finally decided to meet Dr. Fernando Deep and using the international meeting, SAGES 2013. But on that day, the very, very heavy storm attacked the Chicago airport, where I used for the transfer. And almost all flights to the Baltimore were canceled, forcing me to overnight at the really chilly Chicago airport like this guy. But anyway, I finally met him during the Congress, and we wrote the concept of the International Society for Fluorescent Guided Surgery on napkins of the cafeteria at the conference venue. And we decided to create a web page and a list of the core members, and we will publish the textbooks, and also we must organize the international meeting, Congress. After that, I sent a lot of emails to the surgeons and researchers publishing the articles about the intraoperative fluorescence imaging. And finally, we had the first ISFGS meeting in Florida, US, with Fernando Deep and Professor Rosenthal and my boss, Professor Kokudo. And this is the homepage of the ISFGS, and I myself chair the International Congress twice. And next year, we are going to have the 9th Congress of the ISFGS, so please come to present your experience of the fluorescence guided surgery. And we have published the textbooks from ISFGS, and the right one is just published from under the supervision of the Japanese Society for Fluorescent Guided Surgery. And we are creating the consensus guidelines as I presented previously. And we had the SAGES collaboration session also at the ACS this year. And next year, we will have the combined collaborative session with HPBA held in Cape Town, focusing on the near future fluorescence guided HPB surgery. So I mean that our idea has come true. Then now we had 4 regional chapters: Asian Pacific chapter, European chapter, South America chapter, and North America chapter. And we, the Asian Pacific chapter, consists of 10 core members coming from the 10 country regions in our area. Recently, we are expanding to the 14 regions of the AP area. And then I will chair the 3rd annual meeting of International Society for Fluorescence Guided Surgery Asian Pacific chapter in Osaka, Japan, next April. So I'd like to welcome you all to this meeting to share updated information of intraoperative fluorescence imaging among surgeons, researchers, and industry staff, and also to enjoy the full bloom of the cherry trees, sakura blossoms. So thank you very much for your kind attention. Gracias. Thank you.